Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be covering part 4 of the respiratory system for the pediatric patient, and this is going to be cystic fibrosis. So if you've been following me for a while, you know what I'm about to ask you to do. I'm going to ask you to please support me and support this channel by liking this video, subscribing to this channel if you haven't done so already, and don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. All right, so let's get started. Cystic fibrosis, look at what it says. This is a condition that's characterized by exocrine or mucus-producing gland dysfunction that produces multi-system involvement, especially in the pulmonary and digestive system. So what's happening, guys, in cystic fibrosis? The patient is making an excessively large amount of thick, viscous, tenacious sputum that's basically clogging all of their organs. The lungs, the pancreas, the kidneys, you name it. But since we're talking about respiratory, we're going to go ahead and talk about the respiratory portion. However, you need to understand that in cystic fibrosis, all of that thick mucus and secretions that they're making, it's basically clogging all of the important organs, okay? The affected child inherits, look at what it says, autosomal recessive defective gene from both parents with an overall 25% risk of each pregnancy of acquiring defective genes. So I need you guys to understand this. When you see autosomal recessive, here's what they're telling you. They're telling you that there's a 1 in 4 chance. That's why you see this 25%, right? A 1 in 4 chance of getting this disease if both parents have the trait. You can have the trait without having the disease. But if both parents have the trait, there's a 1 in 4 or a 25% chance of having the actual disease. You have to know this, okay? Let's keep going. Let's talk about the pathophysiology of cystic fibrosis. So several clinical characteristics of cystic fibrosis. Remember, guys, they're making a whole lot of thick, tenacious sputum, okay? Increased viscosity, that word's viscosity, that means the thickness. Increased viscosity of mucus gland secretions, and elevation of sweat electrolytes. You need to know that. And then I know it says sweat electrolytes, but they talk about sodium and chloride. So it's like, if it's nasty, don't lick the patient, but if you were to lick them, right, they would taste very salty. Why? Because their sweat is full of sodium and chloride. What else? An increase in several organic and enzyme constituents of saliva and abnormalities in autonomic nervous system function. So something else we have to think about in cystic fibrosis, like I said, all of this thick mucus is clogging up all of the organs, especially the lungs. It's going to be hard for them to breathe. Their pancreas, think about it, guys. What's made in the pancreas? Insulin. So this patient's most likely going to be a diabetic. And remember, the pancreas also releases enzymes to break down food. They're not going to be releasing those enzymes correctly. So this patient's most likely going to need those enzymes replaced, right? So just think about all of the functions of the organs, what those organs do in the body, right? And what happens if they're not functioning properly. And then you have a good idea of what cystic fibrosis is actually doing to the patient. Let's keep going. Patient's going to have decreased pancreatic secretion. So with the pancreas not working so much, that amylase, that lipase is going to be secreted, which means the fat, protein's not going to be breaking down the way it's supposed to. The patient's not going to be making insulin the way that they're supposed to. The last characteristic is the basis for the sweat chloride diagnostic test, where they actually just, test the sweat, and it's going to be high in what? Sodium and chloride. The sodium and chloride content of sweat in 98 to 99% of children with cystic fibrosis, look at this, guys, is 2 to 5 times greater than that of children without cystic fibrosis. So it's going to be way high in sodium and chloride. The primary factor and the one responsible for many of the clinical manifestations of the disease is mechanical obstruction that's caused by all of that thick mucus. All of that very thick mucus that the patient's making is clogging up those organs. Instead of forming a thin, freely flowing secretion, the mucus glands produce a thick mucoprotein, and it accumulates and dilates them. So in the pancreas of many patients, the thick secretions block the ducts, leading to pancreatic fibrosis. The blockage prevents essential pancreatic enzymes, because remember, the pancreas is not only responsible for insulin, it's responsible for releasing those enzymes that actually break the food down, right? So follow me here, guys. That blockage prevents essential pancreatic enzymes, cause marked impairment in the digestion and absorption of nutrients, especially fats and proteins. You see it? It's right here. Don't say I didn't warn you. What did I write here on the side? I wrote needs increased fat and calories in diet. Yep. They need increased fat and calories in diet. Why? Because their body is not absorbing it the way they're supposed to. What else do we see? Look at this, undigested fat. So we're going to see statorrhea, undigested fat in the stool, foul smelling stool. Why? Because that fat that should have been broken down from those pancreatic enzymes. Remember, the pancreas is clogged with all this mucus. It's not releasing those enzymes not breaking down the fat. So it just passes in that patient's system and comes out in the stool. And that's why that stool is full of fat and is foul smelling. Okay, so we'll see statorrhea from the fat in the stool and azoturia from the protein in the stool, because remember, those enzymes are not being released, so they're not breaking down the protein either. What else does the book say? The incidence of diabetes mellitus is greater in children with cystic fibrosis. Well, that makes sense, because we know insulin is produced in the beta cells of the islets of Langerhans. It's where? In the pancreas. Severe insulin deficiency occurs, and that's what leads to the diabetes, the type 1. In the liver, focal biliary obstruction, cholelithiasis, that's your gallbladder, and fibrosis are common. Excuse me. Children develop extensive liver involvement with fatty infiltration despite adequate nutrition. Despite them getting enough of the fat and protein and the nutrients and the carbs, there's still fatty infiltration. You have to think of the disease process. And this is why I keep telling you guys, do not try to memorize. There's too much to know in nursing. You're going to forget. But if you can understand the pathology, it's like a domino effect. A leads to B, B leads to C, C leads to D. If you can understand in that way, no matter how your instructor flips it to you, you'll understand what's going on. Okay, let's keep going. So symptoms are produced by stagnation. That word stagnation means just to stay still, not moving, okay? The symptoms are produced by stagnation of mucus in the airways. Let me stop right there. Whether it's mucus, whether it's blood, whether it's salivary secretions, whenever you have fluid that does not move, guess what? That is a perfect medium for infection. That is a perfect medium for that fluid to now get even thicker, worse. So let's take a look. Symptoms are produced by stagnation of mucus in the airways with eventual what? Bacterial colonization leading to destruction of lung tissue. Whenever fluid is not moving, bacteria is going to grow. The abnormally viscous, thick, and tenacious secretions are difficult to expectorate. It's hard to cough up because it's so thick. Okay, and gradually they obstruct the bronchi and bronchioles, causing scattered areas of bronchiectasis, atelectasis, and hyperinflation. They get so thick, it's hard to cough them up. Air can't get out. So instead of that patient breathing off that CO2, what are they doing? They're holding on to the CO2. That throws them into what? A metabolic acidotic state. Remember, CO2 is acidic. Carbon dioxide, also known as carbon diacid, so you can remember it's acidic. They can't get that CO2 out of their body. That's going to throw them into an acidic state, okay? That hyperinflation is from that gas, the CO2 staying in their lungs. The stagnant, that means non-moving. The stagnant mucus also offers a favorable environment for bacterial growth. Remember this if you remember anything else. If fluid's not moving, bacteria is going to grow. You have another set of problems on your hands. Let's keep going. The glands of the uterine cervix, they're often filled with mucus and copious amounts of mucus, and it can block the cervical canal and prevent sperm entry, because that mucus is so thick and tenacious. More than 95% of males with cystic fibrosis are sterile. Let's keep going. Physical growth can be restricted as a result of decreased absorption of nutrients. Think about it. If they're not absorbing these nutrients, how are they supposed to grow properly? So patients going to have failure to thrive, gradual deterioration of the respiratory system, because you see what all this thick mucus does sitting there, causing them to have infection after infection after infection, causing them to hold on to CO2, causing them to not get enough oxygen in the system. Because think about it. If the CO2 is taking all the space in the lungs, where's there room for oxygen? Okay. Diagnostic testing, evaluation. Universal newborn screening for cystic fibrosis is available in all 50 states. That child is born before they're discharged from the hospital. They're going to be tested for cystic fibrosis. IRT analysis is performed on a dry spot of blood, which can be followed by direct analysis of the DNA for the presence. And for testing purposes, guys, you guys don't need to know this part. The F508 mutation or other mutations on the dried blood spot test. What you do need to know is about that dried blood spot test. That's a test that is a diagnostic measure. A positive screen indicates persistent hypertrypsin. You guys know I can't pronounce. Hypertrypsin. All right, you see it. This word right here. If I had a highlighter, I would highlight it. But this word right here, okay? It's going to be increased, and it does not diagnose cystic fibrosis, but it identifies the patients at risk, and further testing is needed to confirm or rule out cystic fibrosis. The consistent finding of abnormally, remember, the sodium and the chloride is going to be high in the sweat. A consistent finding of abnormally high sodium and chloride concentrations in the sweat is a unique diagnostic characteristic of cystic fibrosis. The parents may report that the infant tastes salty when they kiss them. The quantitative sweat chloride test remains the diagnostic tool for cystic fibrosis. So this is the test of choice. The quantitative sweat chloride test. And what they're looking for is increased number of sodium and chloride in the sweat. Chest radiography, also known as what? Chest x-ray. This reveals characteristic patchy atelectasis and obstructive emphysema. Before I go on to therapeutic management, look at these clinical manifestations. And it makes sense now that you guys understand what's going on. Look, large, bulky, loose, frothy, and extremely foul-smelling stools. Why? Fat's not being broken down, so it comes out in the stool. So that's why it's fatty and foul-smelling. Loss of appetite. That patient's going to have failure to thrive. Weight loss, marked tissue muscle wasting. Think about it, guys. One of the things that's not being broken down or absorbed is what? Protein. They're going to have failure to grow. This has been seen on NCLEX many times. Make sure you know it. Evidence of deficiency of the fat-soluble vitamins. So you need to know your fat-soluble vitamins. ADEK, A-D-E-K. Those are your fat-soluble vitamins. And when it comes to cystic fibrosis, the patients cannot absorb these nutrients, these vitamins. A-D-E-K. Don't say I didn't warn you. Pulmonary manifestations, wheezing. When you're listening to the lung sounds, the lungs are supposed to be clear. When you hear wheezing, that's an adventitious lung sound. That's not good. Why are we hearing this? Because of all that thick, tenacious sputum, mucus that is clogging up the airway. Air can't get through. Progressive involvement. When you see that word progressive, that means as time goes on, it only gets worse. Progressive involvement, overinflated barrel-shaped chest. Why? Because of all that CO2 the patient's holding on to. Cyanosis, no oxygen's going in. Clubbing of the fingers, that's from the hypoxia. Repeated episodes of bronchitis and bronchopneumonia. Why? Because that mucus is stagnant. It's not moving. So bacteria is going to grow. The patient's going to have infection over and over and over again. Let's keep going. Management of pulmonary problems. Okay, patient's going to get antimicrobial agents. CPT, that's your chest pulmonary therapy. CPT has been the cornerstone. Whenever you guys see cornerstone or Hallmark, or a classic, pay attention. That's very important. CPT has been the cornerstone of airway clearance therapy in the prevention of pulmonary infection for many years. What else are they going to get? Postural drainage, positive expiratory therapy, high frequency chest compressions, percussion and postural drainage. PEP, that's the positive expiratory therapy, that's performed by breathing out with a moderate force breathing out with a moderate force through a device. The active cycle of breathing technique is a series of breathing techniques to help the patient to clear their secretions. Here are examples. Pay attention whenever you're studying and the book gives you examples. Usually those examples turn into select all that applies on your tests. So what are these examples? Forced expiration or huffing with the glottis particularly closed, thoracic expansion exercises, relaxation and breathing control. Young children can be taught games with breathing that can develop into these techniques as they get older. What else for therapy? Physical exercise, bronchodilators, nebulizers, IV antibiotics, oxygen administration. Look at this nursing alert. It says signs of pneumothorax are usually nonspecific and include tachypnea, tachycardia, dyspnea, pallor, and cyanosis. Those are signs and symptoms of pneumothorax. A subtle drop in the oxygen saturation. Remember the O2 sat, we get that from the pulse oximetry. A sudden drop can be an early sign of pneumothorax, collapse of the lungs. All right. Blood streaking of the sputum is usually associated with increased pulmonary infection or advanced lung disease. So you see blood in that sputum, you better notify the healthcare provider. Hemoptysis greater than 250 milliliters in 24 hours for a younger child indicates potentially life-threatening event and needs to be treated immediately. Some bleeding can be controlled with bed rest, IV antibiotics, giving them blood, IV conjugated estrogens, Pitocin, vasopressin, and correction of any coagulation defects with vitamin K or fresh frozen plasma. Patient can get anti-inflammatory medications. Anti-inflammatory medications have been shown to slow the rate of decline in pulmonary function. Remember, guys, this is a progressive disorder. So the lungs are only going to get worse, but NSAIDs can slow the progression of it getting worse, okay? So it can give it to slow the decline and decrease the need for IV antibiotics in young patients. And the reason that this is important, guys, the younger you start a patient on these IV antibiotics, the faster that they can become resistant. So this is why NSAIDs are important for the cystic fibrosis patient. Not only does it slow down the decline of the pulmonary function, it also decreases the need for IV antibiotics. Although this therapy is generally well tolerated, careful monitoring for adverse events such as GI bleeding is essential. So that patient's on NSAIDs, you're going to have to teach them while you're brushing your teeth, make sure when you spit out, you look at your sputum to make sure it's not blood tinged. If you urinate or you have a bowel movement, make sure you look in the toilet to make sure that there's no blood there. Lung transplant is a final therapeutic option for many cystic fibrosis patients with severe disease. Management of the GI problems. The principal treatment for pancreatic insufficiency is replacement of the pancreatic enzymes, because remember, the pancreas isn't doing it itself, so they may have to get an external source. These are administered, this is your key, make sure you know it, with meals and snacks. Just like your naturally healthy person who has nothing wrong with their endocrine, every time they eat something, the pancreas naturally will release those enzymes to break the food down. So the cystic fibrosis patient, since their pancreas is not doing it, every single time they have a meal or even a snack, they have to eat it with the enzymes. The enzymes have to break down the food. Okay? It says administered with meals, and snacks to ensure that digestive enzymes are mixed with food in the duodenum. Usually 1 to 5 capsules are administered with a meal and fewer are taken with snacks. Let's talk about capsules. This is important to know. Capsules can be swallowed whole or taken apart. You guys have learned in the nursing program, you never open capsules. Yes, you can in very specific situations, and cystic fibrosis is one of them, when it comes to capsules that have enzyme contents. You see what it says? Capsules can be swallowed whole or taken apart, and the contents sprinkled onto a small amount of food to be taken at the beginning of the meal. Pancreatic enzymes should be taken within 30 minutes of eating because the point is for it to break down that food. The enteric-coated beads should not be chewed or crushed because destroying enteric coating can lead to inactivation of those enzymes or excoriation of the oral mucosa. Why? The reason that it's enteric coated is so that the hydrochloric acid that's in your stomach can protect it, because we don't want it. We don't want those enzymes that are in the capsule to be in the stomach. We want it to where? Go in the duodenum. So that enteric coating protects it. But if you crush it or chew it, that enzyme, first of all, number one, remember what enzymes do. They break down food. If there's no food, but it's your lips, or it's the oral mucosa of your mouth, guess what it's going to start breaking down? Your lips or your oral mucosa of your mouth. So don't do it. It makes sense. Enzymes are mixed into cereal or fruit, such as applesauce for small children, or into a small amount of breast milk or formula for infants. Children with cystic fibrosis require a well-balanced, this is your key, high protein, high calorie diet. Why? Because of the decreased intestinal absorption. High protein, high calorie. Children and adolescents with cystic fibrosis who are 2 to 20 years of age should have energy intake. Look how high this is, guys. 110 to 200% of the standards for a healthy person. Because the uptake of fat soluble, when they say fat soluble, they talk about the ADEK, ADEK. Because the uptake of fat soluble vitamins is decreased, water miscible forms of the vitamins ADEK are given along with multivitamins and the enzyme. When high fat foods are eaten, the child's encouraged to add extra enzymes to break down the fat. That's important to know. Management of endocrine problems. So management of cystic fibrosis related diabetes is critical in the therapeutic treatment of the child with cystic fibrosis. Because remember that pancreas is clogged, so insulin's not being made or secreted the way it's supposed to. Children with cystic fibrosis related diabetes require close monitoring of blood glucose and administration of insulin, diet and exercise management, and quarterly glycosylated hemoglobin A1C measurements. Remember, guys, this A1C gives you a picture of how their blood glucose has been controlled or inadequately controlled for the past 90 days, 3 months. Children with cystic fibrosis related diabetes on an insulin regimen should perform blood glucose checks 3 times a day, preferably before meals. A single daily dose of long-acting insulin may be sufficient for glycemic control, but during illness exacerbations, hyperglycemia may be prevalent. So whenever the patient's sick, remember, when you're sick, your body needs more energy to fight off infection. What do you think is going to go up? The glucose. So during times of illness, you have to teach the parents that they should expect that more insulin is going to be needed. So when that patient's sick, they have to go see the healthcare provider, okay? Bone health is a concern in children and adults with cystic fibrosis. The pancreatic insufficiency of cystic fibrosis and chronic steroid use. Remember, guys, steroids, what do steroids do? Let me stop right here because you guys got to understand this. It has to make sense to you. Steroids, they decrease inflammation, but they metastasize the symptoms of infection. They put you at risk for peptic ulcers. What else do steroids do? They increase your blood glucose. It can cause hyperglycemia. And the fourth one, it makes your bones porous. It can cause osteoporosis. Imagine osteoporosis in a 12-year-old. It's possible. Bone health is a concern in children and adults with cystic fibrosis. The pancreatic insufficiency of cystic fibrosis and chronic steroid use presents potential risk for less than optimum bone growth in such children. Prognosis. What are their chances? What does it look like? The median survival age for the patient with cystic fibrosis is 37 years. Cystic fibrosis remains a progressive and incurable disease. The lung, heart, pancreas, and liver transplantation have increased the survival rates among some patients with cystic fibrosis. Nursing management. Assessment of the child with cystic fibrosis involves comprehensive assessment of all affected systems with special focus on the pulmonary and GI systems. Hospital care. Cystic fibrosis may require contact isolation for their own protection and should wear a mask in communal areas of the hospital. These patients need to be protected from people with infections. They need to be protected from pathogens. Pulmonary complications, aerosol therapy, let me go back actually. When the child with cystic fibrosis is hospitalized for diagnosis or treatment of pulmonary complications, they can get aerosol therapy, chest percussion, postural drainage. All of those are going to be instituted. Again, ACT. We're going to check the patient's pulse ox. Encourage compliance with the therapeutic regimen. They're going to get pancreatic enzymes, vitamins A, D, E, and K. Those are your fat-soluble vitamins. Oral antifungals, antihistamines, anti-inflammatory agents, antibiotics, bronchodilators. Again, ACT, aerosolized treatments. Potential blood glucose monitoring, of course, because that pancreas isn't working the way it should be. Cool and clammy, patient needs some candy. Hot and dry, sugar's too high. You're going to be checking that patient's blood glucose. If it's too high, they're going to need insulin. Home care. Patients and family members need education about, let me move this for you, about the preferred diet of nutritious meals with tolerated fat, increased protein and carbs, and administration of pancreatic enzymes and nutritional supplements. All of these, guys, tolerated fats, increased protein, increased carbs, pancreatic enzymes, nutritional supplements. And they're going to need about 110 to 200% more than your normal healthy adult would. It's important to stress to parents that enzymes in the amount regulated for the child's needs should be administered at the beginning of all meals and snacks, not just meals. If they're putting it in their mouth, it needs to be broken down, right? It makes sense. One of the most important aspects of educating parents for home care is ACT. Again, they're going to get IV antibiotics. The child diagnosed with cystic fibrosis related diabetes should be educated on self blood glucose monitoring, insulin therapy, diet control, and possible related complications. And that's it. That is it for cystic fibrosis. All right, guys, let me know what you thought about this video. Let me know what you'd like to see me cover next or cover more extensively. Don't forget, I do lots of videos on TikTok, Instagram, and Facebook, so be sure to check me out there. And also, I have audio lessons available on my website, nexusnursinginstitute.com. Guys, thank you so much for watching this video, and you guys will catch me on the next video.